Now we have finished discussing the folic acid synthesis inhibitors. Let's move on to talk about the drugs that interfere with bacterial DNA replication, or the fluoroquinolones. All the fluoroquinolones end in fluoxacin or oxacin, and they're all listed here. Here we can see the basic structure of the quinolones. Notice the fluorine molecule present right here, and that gives it its name, the fluoroquinolone. These drugs work by inhibiting DNA topoisomerase 2 and 4 in bacterial cells. Do you remember what topoisomerases do? These are key enzymes in bacterial DNA replication. And do you remember what they do during replication? They are responsible for creating breaks in the DNA and removing supercoils. By inhibiting these enzymes, we inhibit the bacteria's ability to replicate its DNA, and therefore they do not survive. Fluoroquinolones are bactericidal and are used in the treatment of gram-negative rod infections of the urinary, respiratory, and GI tract. They can also be used to treat Neisseria in some gram-positive organisms. Levofloxacin is considered to be a respiratory fluoroquinolone because for some reason it has good penetration into the epithelial lining of the lung. So levo loves the lung. Therefore, levofloxacin is typically used to treat pneumonia caused by strep pneumoniae as well as H. influenza, but it also can be used to treat atypical pneumonias like Legionella, Mycoplasma, Chlamydia pneumoniae. Fluoroquinolones can cause a number of adverse reactions. In general, among all patients who take the drug, common reactions include GI upset, headache, dizziness, can also lead to superinfection and skin rashes. In children and in pregnant women, we can see cartilage damage, and they are actually contraindicated in this population. Also, they must be used with caution in the elderly because they can cause tendinitis or tendon rupture. Tendinitis and tendon rupture are unique adverse effects of fluoroquinolones and therefore are high yield for step 1. Think of the mnemonic, fluoroquinolones hurt the attachments to your bones, to remember this side effect. Daptomycin is an antibiotic that disrupts the cell membrane of gram-positive cocci. Daptomycin is saved and used mostly for drug-resistant gram-positive bugs, including MRSA and vancomycin-resistant enterococci, or VRE. It's important to note that it's used for severe infections like bacteremia and endocarditis. Now let's take a moment to review endocarditis. Remember, the heart has 3 layers. It has the endocardium, myocardium, and the epicardium. Endocarditis is an infection of the innermost layer, the endocardium. Here we can see a classic image of endocarditis, where we can see bacterial vegetations on the leaflets of the mitral valve. Now thinking back to your pathology, do you remember the important clinical findings in a patient with endocarditis? Well, remember the mnemonic from Jane. The mnemonic stands for fever, Roth spots, which are hemorrhages seen in the retina, Osler nodes, heart murmurs, Janeway lesions, anemia, nail bed hemorrhages, and emboli. As a reminder, daptomycin is saved to treat endocarditis caused by resistant organisms like MRSA or VRE. Now time for a flash quiz. Can you tell me what enzyme is inhibited by trimethoprim? And then tell me what enzyme is inhibited by sulfonamides. Well, good. Trimethoprim inhibits dihydrofolate reductase, while sulfonamides inhibit dihydropteroate synthase. Remember, sulfonamides, or S, comes before T in the alphabet, and therefore sulfonamides, you can remember, inhibit the enzyme earlier in the synthesis pathway, or dihydropteroate synthesis, compared to trimethoprim inhibiting dihydrofolate reductase, which occurs later in the synthesis pathway of folic acid. Now let's move on to the last drug covered in the antibacterial section, metronidazole. Metronidazole works by inducing free radical toxic metabolites that damage bacterial DNA. Metronidazole is effective against anaerobes, and it also has antiprotozoal activity. To make it easier to remember what infections are treated by metronidazole, I grouped the infections into 3 groups based on where they cause disease. First, metronidazole treats two important causes of diarrhea, Giardia and Entamoeba. If we think back to our parasitology, what kind of diarrhea does Giardia produce? Well, it produces severe bloating and flatulence, and it leads to a foul-smelling and fatty diarrhea. In what population do we commonly see giardiasis? We see it in campers and hikers. On the other hand, what kind of diarrhea does Entamoeba cause? It causes amoebiasis, or a bloody diarrhea. A liver abscess can also be seen in a patient with an Entamoeba infection. A key differentiating factor between giardiasis and amoebiasis is that giardiasis causes a non-bloody diarrhea, while amoebiasis causes a bloody diarrhea. Here is a high-yield image of Giardia. This is a classic picture that is often shown on step 1, and we can recognize Giardia by the unique-looking features of the parasite here with the kind of the eyeballs that almost looks like a face. The next two infections treated by metronidazole are Trichomonas and Gardnerella vaginalis. This bacteria, Gardnerella and Trichomonas, a parasite, cause disease in the vaginal canal. Finally, metronidazole is used to treat anaerobic organisms below the diaphragm and is also used in triple therapy of Helicobacter pylori. If we think back to other antibacterial pharmacology, can you remember which antibiotic treats anaerobes above the diaphragm? That would be clindamycin. Very good. Finally, it is important to know that the main toxicity of metronidazole is that it can cause a disulfiram-like reaction if the patient drinks alcohol. Disulfiram is the name of a drug that was discovered in the 1920s that is used in the treatment of chronic alcoholism. And do you remember what the drug does? Well, it inhibits acetaldehyde dehydrogenase, a key enzyme in the catabolic pathway of ethanol. Okay, so let's talk about it for a second. How does our body metabolize ethanol? Well, first, ethanol is converted to acetaldehyde by alcohol dehydrogenase. Acetaldehyde is then converted to acetic acid by acetaldehyde dehydrogenase. Now, disulfiram inhibits acetaldehyde dehydrogenase, thus causing a buildup of acetaldehyde, which causes headache, flushing, and nausea. So remember, when you give metronidazole to your patients, make sure to tell them not to drink alcohol. Time for a flash quiz. Can you tell me why fluoroquinolones are contraindicated in pediatric populations and in pregnant women? Because remember, fluoroquinolones can increase the risk for cartilage damage. Now we're going to discuss the antimycobacterial drugs. But before we discuss each drug individually, let us take a moment to review the mycobacterial cell. Here is a nice schematic from first aid that shows us the mycobacterial cell and its main components. Mycobacterium do not fit nicely into the gram-negative and gram-positive categories like other bacteria. Do you remember what lab test we used to identify mycobacterium? We use the acid-fast stain, and therefore these organisms are called acid-fast organisms. The reason that these bacterium do not gram stain well is because of structural differences in the cell wall. Although there is peptidoglycan present, which is the main component of the bacterial cell wall, the main component of mycobacterium is mycolic acid, hence myco. Another unique component of the cell wall is arabinogalactan. These two molecules are important because they give us a target to treat with medicines. In fact, the mainstay of therapy for mycobacterium is the inhibition of mycolic acid synthesis with the drug isoniazid. The three most clinically relevant mycobacterium are Mycobacterium tuberculosis, Mycobacterium avium intracellular, and Mycobacterium leprae. These bacteria do not cause severe disease in immunocompetent individuals. For example, Mycobacterium tuberculosis is very easily spread in the air, but it only causes active tuberculosis in a small percentage of those infected. And do you remember what kind of symptoms you would see in someone with active TB? We would expect to see a patient with fever, night sweats, chronic cough, weight loss, and fatigue. If you see any of those or number of those on your exam, make sure to be thinking of Mycobacterium tuberculosis. Here's an image of Mycobacterium tuberculosis. We can see here the granulomas that form and surround the organism. Do you remember the distinctive cell type that is found in these granulomas? That is an epithelioid histiocyte. Very good. And which immune cell turns into the epithelioid histiocyte? Well, these are actually macrophages that fuse together to form a large epithelioid histiocyte that helps form the granulomas. Very good. Mycobacterium avium intracellular rarely causes disease in immunocompetent patients, just like tuberculosis, but is important because it is a common opportunistic infection in AIDS. Here's an image of Mycobacterium avium intracellular. Can you see the acid-fast organisms? These are the pink rods, as we can see here. An acid-fast stain stains the organisms pink. So if you see an image like this on your exam with pink rods, start thinking about Mycobacterium. Here's an image of Mycobacterium leprae. See the acid-fast rods again. Do you remember what cell in the body is infected by Mycobacterium leprae? It's the Schwann cell of the peripheral nervous system. And what disease does Mycobacterium leprae cause? Well, it causes leprosy. Very good. And remember, there are two forms of leprosy, the tuberculoid and lepromatous forms. An important thing to know about antimycobacterial medications is that they are both used to treat and prevent infection prophylactically. So when do you think you would give the medications prophylactically? Well, we would give these medications to patients who are immunocompromised or who would suffer very serious disease if they happen to be infected by any of these bacterium. So it helps prevent the infection from becoming serious disease in those with immunocompromised states. Very good. So do you remember which drug we talked about that inhibits mycolic acid synthesis? That's isoniazid. Very good. Isoniazid is used as monotherapy or single therapy in prophylaxis of Mycobacterium tuberculosis, and it's also used in the multi-drug cocktail for the treatment of active tuberculosis. The mnemonic RIPE is helpful for remembering the 4-drug cocktail that is used for the treatment of active tuberculosis. These drugs include rifampin, isoniazid, pyrazinamide, and ethambutol. Azithromycin is the drug used for prophylaxis against Mycobacterium avium intracellular. Azithromycin can be combined or used with rifampin, ethambutol, and streptomycin in very serious disease. There is no prophylactic medication for Mycobacterium leprae, but to treat these medications, you can use combinations of dapsone and rifampin to treat the tuberculoid form, or you can add clofazimine to treat the lepromatous form. Do you remember which of these two forms causes more serious disease, tuberculoid or lepromatous? Well, you can imagine if you have to add a medication to treat lepromatous form, this is probably a more serious form of leprosy.